and our keynote speaker is Dr. Barbara Ferrer. Dr. Barbara is the Health Director for Los Angeles County Department of Public Health. You see her every day on the news as she gives her report out in terms of what's happening with COVID-19. She's going to share a presentation with you, and then we have a couple of questions of her, and then we'll move towards adjournment. Dr. Ferrer.
Good afternoon, and thank you so much for really inviting me. I'm honored to be with everyone today, and I'm especially grateful that I had this opportunity to hear from this amazing group of panelists. So much wise counsel for, I think, all of us, but particularly for those of us in government. I also want to give a big shout out to Cindy. Her words and her story are powerful, and I think they do in this, extraordinarily challenging time. I see them as sort of a grounding that allows us to continue to get up every day and do what we need to do, which is a lot that's in front of us. I do also want to acknowledge, I had heard that there are some USC public health students that are listening today, and we have a passion for those of you who are engaged in public health work, and want to really thank you for making time to come on this, I think, very important conversation about what does the work need to look like as we move ahead. And I do want to thank all of the panelists again. Your brilliance and your commitment makes it possible for all of us to both have hope and sort of have some idea about what a successful path forward might look like. I do want to acknowledge that there's a few members of our public health team that many of you know, and I know sometimes people, sort of look at me and, as really the face of this department, but I'm actually not. I represent thousands of people who make a difference in everyone's lives, who come together every day, come to work every day, particularly during this pandemic, have enormous skill, commitment, and leadership in how we can move our work forward during a pandemic. And so there are a couple of folks I just want to shout out from the Trauma Prevention Initiative team. You know many of them, starting with Andrea Welsing, who's the director of our violence prevention work, including the Office of Violence Prevention, but also Kelly Fisher, Keith Baker, Artie Harper, and Patty Hernandez. Many of you have worked with them. They're active in the South LA communities as both members and partners. So I just want to make sure I recognize them. I also want to thank Cheryl Branch at LAM because she works a lot with us at the TPI team, and she's really, I think, given us really good guidance about how we can support community networks that can come together during times of devastation. And this is certainly a time of great devastation. And I want to also thank Robert. His leadership, I knew him from before, but his leadership at CRSSLA and also the advocacy for all of the work he's been doing in South LA, I think stands as a reminder to us of that there is power in one person. So I want to acknowledge you've been powerful, you continue to be powerful, and it's just a great honor to have an invitation to come today because of your long history of commitment. And again, I'm a person who has benefited from other people's both mentorship and dedication and actions that they've taken. I don't stand here by myself and never have. And I want everyone to know I have such enormous respect for the work that's being done. I did want to just start by noting that for us in public health, it's more important than ever that we're supporting our community leaders and essential workers who are working on the front lines, as are communities of color, particularly the Black African American community, from the devastating impacts of COVID-19, from racial violence and police brutality. It is important that we lift up an urgent call to action and that we support the efforts of those people that are leading work fighting for racial justice and law enforcement reforms as part of both peaceful protests and civil uprisings across the county and across the country. We do know that Black Americans fare worse than all other groups on virtually every measure of health status. And it's become all too common to blame this on individual behaviors, when in fact the science is clear. The root cause of health inequities is racism and discrimination, and how it limits the very access to opportunities and resources that each of us will need for optimal health and well-being. Science also tells us that lifetime stress associated with the experiences of daily acts of discrimination and oppression play a major role. And it starts at birth with higher rates of Black infant mortality and shockingly higher rates of maternal mortality among Black women. And it extends through adulthood when we see Black residents of LA County experiencing earlier onset of heart disease, hypertension, diabetes, and much earlier deaths. When I report each week that we've seen elevated numbers of Black deaths in this county due to COVID-19, I'm reporting on the consequences of these longstanding injustices and inequities. Racism is and always has been a public health crisis. And I know I had a series of questions, so I'm going to try to, see if I can get to all of them in a few minutes. Starting with a request to just go over and highlight some of the data around COVID-19 here in LA County. Today I reported a total of 81,636 cases. Unfortunately, we've also lost 3,110 people to COVID-19. And our hearts go out every day to the families and the loved ones of people who have passed away from this terrible virus. They're with us in terms of our prayers and thoughts as we work and move forward. I want to acknowledge that I've been reporting for the last 2 months about the increasing disproportionality around the impact of COVID-19 in LA County. And it's not just in LA County, but I think it's important to focus on what's happening right here at home for all of us. So I want to share just the numbers around what we see around deaths. The numbers in and of themselves, as I noted, 3,000 people losing their lives in a very short period of time. If this pattern continues through the rest of the year, COVID-19 is likely to be the leading cause of death here in LA County. So none of this is inconsequential, and it all is out of the ordinary and like nothing we've ever seen or experienced. But I also want to note that the profound inequities that we see are unfortunately the same patterns of inequities that we have seen before and have not successfully in any way managed to dissipate or narrow these gaps. So for COVID-19, if you're Black American, you're dying at a rate of 35 deaths per 100,000 people. That's the same death rate if you're a Latino, Latinx resident here, 35 deaths per 100,000 people. If you're a Native Hawaiian or other Pacific Islander, your death rate is actually 52 deaths per 100,000 people. The numbers are relatively small, so for those of you who are statisticians, you'll note we have a lot of variability in the confidence intervals there, but it's still an extraordinarily high rate of death. And I like to say, even for our Asian residents, the death rate has crept up and it's now 24 deaths per 100,000 residents. That compares to the death rate for white residents in LA County of 19 deaths per 100,000 residents. And that gap has persisted throughout this pandemic at the point that we were able to make sure we had good quality data to really think about what was happening around deaths. And it should be beyond troubling for all of us to see playing out in front of us in real time, this gap in the experiences that people have in terms of the impact of a pandemic. I want to also note that the gap is fourfold if you look at communities with high rates of poverty, which, as we all know, in LA County are also communities predominantly of Black and Brown sisters and brothers, neighbors and friends. And there, if you're living in a community with a high rate of poverty, the death rate is actually around 8,000, around 61 deaths per 100,000 individuals. If you're living in a community with relatively little poverty, the death rate is 16 deaths per 100,000 people. And so the question I think before us is not just that this is alarming, but as a public health department, what are we doing? Because it's not really beyond insufficient. It's actually would be destructive to note a disparity of this magnitude and not have figured out by now what's a realignment of resources that would actually help narrow this gap in real time. So I want to talk for just a few minutes about what that realignment needs to look like. Then I want to talk a little bit about what are the approaches to doing this work, because I think a lot of what was talked about so eloquently by the panelists is, how does government make sure we don't misstep in this effort to right a fundamental wrong? But I do want to start with the work that has been done to date. And for those of you who know our department, I want to acknowledge that this work has been headed up by our health officer, Dr. Muntu Davis, and by our regional health officer, who many of you know, is Dr. Jan King, who works in our South LA region as well. And what they did is they did bring together lots of different folks to help us look at this information, and then really do a deep dive as what are the factors that are contributing to what we're seeing today, what's both short-term areas for us to think about additional investments, and then what's the long-term work around dismantling racism and becoming ourselves an anti-racist institution, really dealing head-on with anti-Black racism in particular, but also acknowledging that there's a need for us to stay committed to the struggle that's been ongoing and also to change what's happening today. So the areas that we identified where, with again, our community partners, the areas where we identified where there's need for immediate action and that we have a role that we need to be playing is around access to testing, access to health services, access to social support, and protections for workers. So I want to start with the access issues. We looked early on at the data around who was getting tested, and no surprise, people with more resources, with more money, were much more likely to be getting tested. People with less resources and less money were much less likely. And if you looked at where testing opportunities were located when the pandemic first began here in LA County, there was a lot of disproportionality. And I want to really thank both the fire department and the Department of Services that are charged with the testing strategy for quickly moving to open up many more testing sites in other communities so that there would be a lot of easier access. But I also want to acknowledge the limitation of drive-through testing. It's not connected to people's providers, and it's not connected in particular to trusted providers in the community. And that's hurting us. A lot of people do not want to go to the mobile testing sites. They're worried about what's going to happen with the data that's collected there, with the questions that get asked, and whether or not they're actually having access to a reliable test. Because a lot of questions are being raised about the reliability of the tests that are being used. So there are legitimate questions out there, Our job right now is to figure out a strategy that allows testing to be embedded again in trusted community partners, our federally qualified health centers, even individual providers that have actually stepped up and said to us, with support and resources, they would be able to actually offer this to their patients and to other people that live close by in the community. So that's the effort right now. Is it's not just about moving the testing sites into communities where there was no access to testing. It's really about connecting back with trusted community partners about how to do that testing. It's particularly important for COVID-19 that the testing actually be embedded in healthcare settings, because for many people who have underlying health conditions, they're at serious risk for the devastating impacts, both higher rates of hospitalization and unfortunately, much higher rates of death. 93% of people who die from COVID-19 have underlying health conditions. That number hasn't changed. We've known that almost from the beginning of the pandemic. So the strategy has to be to make sure that people with underlying health conditions have protections that protect them from being exposed, but also if they do end up being positive, there needs to be a rush to provide them with good services. The third bucket that I mentioned was social support. Cannot quarantine, cannot isolate without a lot of support. This is particularly true for people with less resources, who don't live in homes where there's 5 bedrooms and 5 bathrooms, and every person that's positive has, sort of easy access to the isolation and or quarantine instructions that we're giving. There are quarantine and isolation facilities that were set up across the county to help folks who couldn't do it at home, but those are limited in terms of their acceptance in some of our communities. So we have to work harder to help families figure out what's the best options for them around quarantine and isolation. But that's the tip of the iceberg. Underneath that is sort of what happens if you're the person who earns the money in the family. And you're asymptomatic, and we're now saying to you, you can't go to work, and there's no pay that's going to come in, and it's really unclear how you would get resources. Or even worse, if you're a person who's asymptomatic and you were close contact, and we tell you, now you're home for 14 days. You can't go to work. So that social safety net, it has to be there. We have to make sure people can get food if they need to quarantine and isolate. We have to make sure that there's some economic security there. And we have to make sure that we deal with some of the housing challenges, or this just won't work. The containment strategy right now with everything reopening is that there's going to be a lot of testing, and then we're going to make sure that people have what they need so that they can quarantine and they can isolate once appropriate. But can't do that if you don't have the support services. So those are 3 buckets that we feel we have a role to play, so do a lot of other people, in making sure that we're being honest about what it takes to actually follow a public health directive, and that it's not equally easy or even possible for everyone to do what we ask them to do. And it's our job to try to shore that up. The way we would shore it up, I'll talk about in a minute, is to work with getting resources out to our community partners so that that becomes something that community organizations trusted in the neighborhoods actually have resources to get the kinds of things they're going to need during this very disruptive time. I want to talk about the last thing because I think, from our perspective, we haven't paid enough attention to worker protections, and I don't think others have either. So if you think about why this pattern of disproportionality is so acute, I don't think any of us could not trace this back to who were essential workers and who are workers going back to work now in the low-wage jobs where there's not as much protection as they ought to have. So even with essential workers, we who were ahead of almost every other county did not require masking until mid-April. Of essential workers. That was when the only thing that was open was essential workplaces. But we were 2 months into the pandemic before we realized, A, that there was a lot of asymptomatic spread, and B, that it wasn't enough to just tell people that they were safer at home, because there were millions of workers that had to go to work every day. And that's the situation that we find ourselves in again today with all of the reopening. So on May 13th, we actually ordered everyone to wear a face covering. But even beyond that, what we've done, and I don't think it's necessarily sufficient, but I think it's the place to start, is we have issued in our health officer orders directives for all the sectors that reopen. These are not recommendations. And there's a lot of confusion about that because at the state level, they're issued as recommendations. Ours are not. They're directives, they're requirements. You cannot reopen unless you put in place basic worker safety issues. And customer safety issues. But the big gap is around protecting workers. So if you look at what we call protocols, you will see embedded in there are a set of directives that include the appropriate PPE, that include the appropriate distancing. Where that's not possible, there's the erection of physical barriers that's required. That requires that everyone have a testing plan for when they do have positive cases, and that employers take responsibility for that testing plan, that require reporting to us of positive cases. And most importantly, I think that require that the protocol, which is written as a checklist, be shared with every single employee who's at the site so that employees know what that employer was required to do prior to reopening. Now, the reason I think it's an appropriate action for us to take. It's insufficient in some of the sectors because it's very hard for us on the enforcement side to get out to everyone. We do have a complaint line. We do urge people, again, to talk to us. We are looking for additional funding to fund worker rights organizations in the communities to really help make sure that this pandemic, the serious illness and the deaths are not on the back of workers, particularly low-wage workers who are not working in a unionized sector. We hear stories. We're looking into every example that people get to us where they feel like there's an industry that's just in flagrant violation, and we do send our inspectors out. But I want to say, this is a huge, huge county, and this is an area where we need to make more investments with our community partners about lifting up issues related to worker rights. Because if we don't do this quickly, we will continue to see an increase in the disproportionality, and we will have not done something that we know would make a difference in the trajectory of exposures, and that is really minimizing exposures at work. I don't have to go to a restaurant to eat, but restaurant workers are in many ways compelled to go back to their jobs if they want to keep their jobs. So, when people fight us because we require face shields in addition to the cloth face coverings for the workers there, we're requiring it because people are eating and they don't have a face covering on. And if you don't have a face covering on, you don't protect anybody else. So those workers need an extra layer of protection if they're going to do that job. So we get a fair amount of pushback, but I want to say I think it's where we need to do some very important work moving forward. We do need to protect workers who are now going back to work, as well as acknowledge that we were not able to do the job we needed to with essential workers who were back from who never left their work at the very beginning. And I think that's fueling the trajectory that we're seeing around disproportionality. I want to just close with I want to really both thank all the panelists for acknowledging that how government shows up matters more than anything, and that this is a partnership. And we can never, it would be so inappropriate for us to ever tell anybody what they need to do in order to work with us. It's our job actually to ask you what we need to do to work with you. It's a paradigm shift. Our organization has been working hard to come to all of our work, not just our COVID-19 response work, that we are in service of our communities and our residents. And that our job is to listen, to take guidance, and then to offer support that's appropriate based on what the people closest to the problem with, I think, the best knowledge about the solutions to the problems are going to ask us to be ready to do. And I think you've seen some examples of that approach in the TPI work. I think, again, you've seen some examples of that in the work that we did to even create the Center for Health Equity, spending 6 months actually just listening to what people in our communities and organizations in our communities wanted to see from us. I've always said that if you really want to fight racism and you're an organization as big as ours, you got to be an all-in organization. Like every single thing we do has to be about really becoming an anti-racist organization from, what's happening internally, but like who do we contract with? We have a huge budget and a lot of money goes back out to the community, quote unquote community, but who is it really going out to? And I like the comments about like our contracting doesn't really work. Sometimes the way we pay, you have to actually accrue the cost before you're going to get reimbursed. I mean, there are lots and lots of fixes that have to happen here. But I think there's an awareness that that's the road we have to be traveling on right now. We have to sort of fix these systems that stand in the way of making sure that what we're doing is actually supporting what's needed in our communities as determined by people living and working in those communities. So I'm gonna
let me jump in here real quick before you got to go. Let me just say to our audience that we're probably going to run about 2 to 3 minutes behind, but got a couple of really important questions. First and foremost, I appreciate that you did cover the COVID-19 crisis. Here's the message I got from that. COVID-19 is not over. The message that I've been giving to people is that testing is not a cure. So your testing is only as good as the time you got out of your car, got tested, and got back in it. You could have caught it in line.
Yeah.
Now, what I want to make sure that we understand on the testing front with respect to the African-American community, especially with our topic, saving lives through effective community engagement, is I believe one of the reasons that African-Americans are reluctant to test is because there's been a lot of experiments on our community, from the Tuskegee experiment and so on. And we hear that. Those are just conversations what we have. So in the context of Black Lives Matters, your office, prior to that, published a racial equity report during this COVID-19 crisis, but we've not seen any of the senior African-American leaders in your department, like Dr. Montu Davis and Dr. Jan King, in visible roles. We haven't seen Black faces in Black spaces. And so when we see the weekly and daily updates, that was the case with the city as well at one point, but I believe there's a level of discomfort in the community. So I imagine we'd have to ask the question of what's the plan to ensure that we have Black faces and Black spaces, and we're seeing the leadership. Dr. Montu, for example, is the chief health officer who signs off on all orders. Most people don't know that. And I think when we start to do that, it would help drive a level of trust from the community when they see people who look like them, and particularly in the context of Black Lives Matter. I'll throw that out first. That's my first.
Yeah, and I think it's a great question. So, I'm going to answer it in two ways. One is, we were hopeful that Dr. Davis would be the person actually speaking today. He does do a lot of telebriefings and a lot of town halls, as does Dr. King, as do all of sort of the physician leaders for at the department. And so I do want to note that it was at your request that I'm here instead of him, because he was available, and he is in fact brilliant and leading so much of the work at the department, as you noted, and does a fair amount of sort of our we do a lot of community outreach still virtually now, and certainly at the beginning of the pandemic it wasn't virtual yet. He was a trusted messenger at the very highest level, as you noted, of this organization. I do want to point out that things are pretty ugly out there right now for the public health leader, not just here in LA County, but everywhere in terms of threats and hate. And so I'm the only front person on that media briefing, because there really is just one person that needs to put up with all of that, and that's going to be me. for a variety of reasons. So we're very careful at this point because there are threats and there's a lot of hate mail, and it's uncomfortable and unwise to actually, at this point, create a lot of forums where more people in my organization are going to be subject to that kind of treatment. I know people are angry and I know people are upset, but I'm going to be the only target for all of that at this point.
Yeah, and I get that. I guess my challenge is this: what I'm not seeing in addition to that is, and I've talked to many African American physicians, for example, in the community, and I think overall we're not seeing those Black faces in Black spaces. And what we're talking about when we talk about community engagement is about building trust. Yeah. And so when you have people who are showing up looking like the quote unquote savior as opposed to engaging in that process, I just think that needs to be rethought through. And I think it needs to, we need to make sure that the community, particularly of South LA, sees those types of faces in our community. I mean, hey, I get death threats all the time as a leader of community build and other types of threats, but it comes with the job, right? But I don't stop there to not communicate. It's very important that we do that. The other question I'd put out there to you is, after hearing how important today co-design and community engagement is in flattening the curve for COVID-19, and knowing the community engagement budget is already budget dust as compared to the total budget of the Department of Health, how can we ensure that that the budget dust with the upcoming budget cuts doesn't get blown away, but stays stable and perhaps even funded more, so that we do get the proper messaging to Black faces and Black spaces?
Yeah, I mean, there's so little certainty right now in anything, but I think from our perspective, we know we can't do this work without the partnerships, and the partnerships require, a robust set of resources. So, we're going to do everything we can to make sure those resources are going out to the community partners. As a matter of fact, we've been approached by funders to support us, and we have actually asked, instead of supporting us, that they support community-based organizations directly, not funnel money through us, but actually, have made suggestions about, different areas where we think there are community-based organizations that can do the work that the funders are interested in supporting. It's really important work. And we'd like that money, again, to go to community-based organizations, for them to work on, what are the strategies that are going to be meaningful in communities. How do you actually create the kind of opportunities that people need? I really hear you on sort of the testing issues, even, some of the basic issues around providers, getting them PPE. I mean, there's just such a long list of this at this point of resources that are needed.
Right.
And we'd like to encourage as many people as possible to help make those investments with us. But you have my promise that we know these investments need to get made, and we're going to continue to do our very best to make sure that this work moves forward in the only way I think it can, if it's going to be successful, which is through partnerships.
Right. Well, we certainly appreciate that. We're reaching the end of our time. And so I do want to just reach back out to Pastor Calloway for maybe 60 seconds before I wind up. But before I do that, Dr. Barber, I just want to say thank you very much. I know your calendar is full. I know that there are many requests, and in addition to just the regular work that you have to do. So we appreciate you.
My honor.
Yeah, we appreciate that. And more to come. So stay tuned for more to come from the Department of Health. And then we'll continue this dialogue.